pH was the central parameter. The disturbances were respiratory and metabolic, being affected by PCO2 and bicarbonate. Right? Now we move on to Stewart approach of acid-base balance. Okay. Now what happened is that people, although the traditional method is easy to use and it's been there for a long time, all of us have been using it day in and day out, and it's very useful for the usual management of patients. But patients in the ICU, it can get quite complicated. It was also increasingly realized that electrolyte disorders are very much important and have a great influence on acid-base status of the patient. And so Stewart approach included the effect of electrolytes on acid-base disorders. So what did he do? Right? He said in his concept is the base excess that is a central parameter that you need to use to analyze acid-base disorders. So base excess is affected by arterial carbon dioxide as usual, but it's also affected by what is called the strong ion difference and also by total weak acids. Okay, so base excess is a central parameter. It is affected by strong ion difference and total weak acids. Okay, next thing. Okay, so what he did was he put all the cations into one cylinder. Okay, and all the anions into another cylinder. Okay, and this kind of depiction of cations and anions is called a Gamblegram, based on Dr. Gamble, who actually proposed this. Okay, so it's called a Gamblegram, not that somebody is gambling. Okay, so you have cations and anions in cylinders like that. Okay, the rule is that the cations should be equal to anions, means electroneutrality must be preserved, that is the columns must be equal in height. This is a very important concept. Okay, if you look at the cations, of the strong cation, sodium is a major player. Okay, potassium is also there. Of the strong anions, chloride is a major player. Bicarbonate is only a major but weak anion. It's not strong, it's a weak anion, but it determines the pH. Okay, there is also some albumin, which is again an important anion. And so the difference between the strong cations and the strong anion is called the strong ion difference. Strong cation minus strong anion is strong ion difference, which is normally 40 milliequivalents per liter. Okay, we may have some, if you can see the white band, that represents lactate and all other highly dissociated organic acids present in small concentrations, such as sulfate, phosphate, ketones, etc. So it should be negligible. Okay, so the bicarbonate changes in parallel with the strong ion difference to maintain electroneutrality. So bicarbonate is sort of a dependent ion. It changes with the difference in these strong cations and anions to maintain electroneutrality. So that is its role. Okay, so the strong ion difference, also mentioned as SID. Okay, the normal would be 30 to 40 millimoles per liter. Okay, as SID decreases, you can see the hydrogen ion concentration increases and there is acidosis. As SID increases, there is hydrogen ion concentration decrease, or hydroxyl ions are going to increase, the pH is going to increase. So SID decrease, pH decrease, and acidosis. SID increase, pH increase, and that is alkalosis. Something for you to remember. So let's take examples. Okay, on the left side, you have this Gamblegram for a normal situation. You have the sodium and you have the chloride and all the rest. Now this is the question that we have. Okay, let's see what's happened here. The sodium has gone up to 150 from a normal of 140 in this particular patient. So the height of this column goes up when a patient retains sodium. That is not acceptable. The body has to maintain electroneutrality. Chloride has not changed. So what happens? The bicarb will increase so as to maintain the size of the column, or rather electroneutrality. Okay. Now remember, SID calculation is sodium minus chloride. So 150 minus 102, that is 48 millimoles per liter, or milliequivalents per liter. Normal is 38 or 40, we said. Okay, so this is on the higher side. What did we say from the earlier picture? If SID increases, that is alkalosis. So this patient has developed alkalosis. Okay, now remember, when sodium increases in the body, it's usually because of reduction in water. So plasma volume has gone down. So that's why it's likely that this patient has plasma volume contraction. And so that's why this is called contraction alkalosis. That is what this patient has got. Okay, right. Now, I have a question here. Now, what I saw in part 1 is that we have had about 6 respondents and all the responses are correct. For good interaction or for good understanding, we would like more people to participate. So please indicate your answers in the chat box so that we can also know that you're interacting. So I sincerely request more people to participate, please. So now we are moving on to question 9. What acid-base disorder can be produced with the infusion of large amounts of isotonic saline? We have all been writing MCQs and giving tests, all that entrance tests. I'm sure you've written answer to this question. Michelle, have you answered this kind of question?
Good evening, ma'am. Ma'am, when we infuse sodium isotonic saline, then what usually happens is in isotonic saline, the amount of chloride available is 154 millimoles
Wait. Just choose what have you heard? You don't have to calculate and tell me. Just tell me, what do you know? People tell you not to resuscitate with large amounts of isotonic saline because it produces
usually produces metabolic
acidosis. Yeah, that's all I want you to tell me. Right? Okay, so you're right. We all know that large amounts of isotonic saline when used for resuscitation produces metabolic acidosis. So I'm going to explain to you. Michelle is right, okay, and I'm sure she knows why also, but I will explain that to you, okay? Right. Yeah, she's right. I think she may have drawn Gamblegrams for all I know, but maybe not. Okay, what happens when you infuse a large amount of saline, as the sodium goes up, 147, chloride 128 is what's happened. Chloride is increased so much more, and because of that the column is going to change and bicarb is going to be thrown out. When chloride increases, it will throw out the bicarbonate, and so there will be what is called hyperchloremic acidosis, right? I'll illustrate that in a minute. Let's calculate the SID here. Okay, sodium minus chloride. Sodium is 147, chloride is 128, the SID is 19 millimoles per liter. We said normal is 38 millimoles per liter, but SID here in this case has gone down to 19, so that is acidosis. Okay, and this acidosis has happened because chloride has gone up, so we say hyperchloremic acidosis. Now the question comes to your mind. We have given saline and it contains equal amounts of sodium and chloride. So both should have gone up together. Why did the SID decrease? That's a natural question that we would have. To understand that, let me illustrate, okay? Okay, before that, let's look at this. We said sodium and chloride are in equal amounts in saline. So how much does it contain? I'm sure you know sodium contains this in 0.9% saline. We have 154 millimoles per liter of sodium and 154 millimoles of chloride. So what is the strong ion difference of isotonic saline? Vasudha?
Yes, ma'am. The strong ion difference will be sodium minus chloride, which will be equal to 0.
Yeah. So that's a very easy question, isn't it? I've also given the clue. So that's good for you. Yes, you're right. It is 0. Right? So coming to the question, so we're giving equal amounts of sodium and chloride into the plasma. Why is the patient developing acidosis? Okay. To illustrate that, we have these pictures here. Okay, we have plasma. Let's take a liter of plasma, and then we add a liter of sodium chloride to that. Okay, the plasma has sodium of 140 millimoles per liter, chloride of 1 or 2 milliequivalents per liter, and the SID is 38 millimoles per liter, milliequivalents per liter. Okay. If you look at the saline, we said 154 and 154, and we said the SID is 0. We all agreed on this. So we're mixing them up. What will we get? Okay. So we get 2 liters volume. What does it contain? Now we have to see sodium. 140 plus 154 divided by 2. That would be the sodium. So you get 147. So we see that the sodium has gone up from 140 to 147. It's gone up, but not so much, only 7 millimoles per liter. Chloride, what's happened? 102 plus 154 divided by 2 is 128. There's a much more increase in chloride levels compared to before. And so you get hyperchloremia. What's happened to the SID now? What was 38? Now it becomes 147 minus 128 from 19. So it's become 19, right? So from 38, it's become 19. So what was normal pH has become acidosis. So that is why when you resuscitate patients with large amounts of normal saline, patients can develop hyperchloremic acidosis. That is the illustration. Okay. So does that happen with ringer lactate? Example, okay, we have the same plasma there. Let's see ringer lactate. You have sodium 137, chloride 109, and lactate 28 millimoles per liter. So if you look at the SID, again, like saline, it is 0. Okay. But remember, yeah, that is because lactate is a strong anion. SID of ringer lactate is 0. Okay. Normal pH, so in the plasma, SID is 38 as before. We have mixed them up now. We get 2 liters of ringer lactate in the plasma together. So let's see, sodium 140 plus 137 by 2, 139 millimoles per liter. Chloride 102 plus 109 divided by 2 is 105 millimoles per liter. Lactate gets metabolized in the body, so it doesn't stay there anymore. And so it doesn't come into your calculation at all. It gets converted to bicarbonate, it's eliminated. Okay. So the SID of ringer lactate, once it's given into the body, it's going to be 34 millimoles per liter. And because lactate gets metabolized and SID would change only from 38 to 34, and so there is no acidosis. So that's why you can use ringer lactate as a resuscitative fluid. Okay, right. Next situation. Let's see what's happened in this particular patient. All right. Okay. What's happened here? You have the sodium, the same, chloride, the same. Bicarb seems to have increased. And why has that happened? That's because albumin has gone down. Right? So if a patient develops hypoalbuminemia, the column of anions is going to decrease, and that's not acceptable. So bicarbonate will increase to fill up that space, and so you get what is called hypoalbuminemic alkalosis. Okay, what has happened to the SID here? Okay, that's again 38. Okay, right, so it's maintained, but alkalosis is induced by hypoalbuminemia. Right, so I hope you understood that. Okay, so we were talking about SID. What is SID? We said sodium minus chloride is SID. Strong cation minus strong anion is SID. This must be equal to the bicarb plus albumin and phosphate. Okay, you could also write it as SID apparent is the sodium minus chloride. SID effective is bicarb plus albumin and phosphate. That is SID effective. Okay, normally SID apparent and SID effective should be the same. Okay. However, if there are unidentified or unmeasured anions in larger quantity, then there is going to be a difference between the two. The difference between the SID apparent and SID effective is also called strong anion gap. That is called SIG. That was SID. This is SIG. Okay, strong anion difference. This is strong ion gap. Okay. So normally this must be 0. You don't want unmeasured anions. So it should be 0. Okay, something like lactate, sulfate, ketones and all that, that shouldn't be there. So it should be 0. Okay, so let's have a look at these different fluids that we use day in and day out. You have plasma with this metabolizable and bicarb lactate, whatever is there. Okay, so plasma has a SID of 38 millimoles per liter, we said. Look at ringer lactate, that also has a SID of about 28 millimoles. You can see very similar. Okay, you can see metabolizable anion in acetate. Ringer acetate has that. Ringer fundin has acetate and malate. Okay, to replace this, whereas saline doesn't have any of these. Okay. Yeah, so SID is replaced by metabolizable anions in these crystalloids that we use other than saline. It's just something for you to know. Okay. Right, so this is what Stewart mentions. Right, base excess is the main parameter that you need to look at, which is affected by arterial carbon dioxide as usual. And you have strong ion difference affected by sodium, potassium, chloride. Okay, and you have total weak acids, albumin, phosphate, unmeasured anions and cations. Okay, so this was the other faction. For most concepts, you have two schools of thought, right? You have traditional method and you have Stewart's method, and there's always a competition. So the people who are following Henderson-Hasselbalch equation said, okay, yeah, we agree with you that there is effect of electrolytes. Okay, they also looked at the albumin levels, metabolic disorders, and serum albumin. So they said, okay, we accept that hypoalbuminemia causes metabolic alkalosis and that it can mask metabolic acidosis. So we'll correct anion gap for albumin. Remember the calculation for anion gap that we had earlier? So if serum albumin is less than 3.5 grams per liter, we will correct anion gap for albumin. So they came up with this, saying corrected anion gap is equal to observed anion gap plus 2.5 multiplied by 4.5 minus measured albumin in grams per deciliter. Okay, so see, we can correct that. Okay, right. So if serum albumin concentration is normal, measured anion gap will be equal to corrected anion gap. So we now have a calculation to come up with do. So we had this diabetic patient in the ICU in shock. We said observed anion gap was 20 millimoles per liter. We did that calculation already. Let us say his albumin was 2.5 grams per deciliter. I'm sorry, it should be deciliter here. Okay, calculate corrected anion gap. Okay. Can I have Alankrita do this calculation?
Good evening, ma'am. As per the formula, the corrected anion gap will be observed anion gap, which is 20, plus 2.5 into 4.5 minus the measured albumin, which is 2.5. So this comes to 20 plus 25 into 2, 20 plus 2.5 into 2, which comes to 20 plus 5. So corrected anion gap is 25, which is option number C.
Very good. Excellent. Okay, excellent. That's right. Your answer is right. Okay. Yeah, I hope some of the viewers at least got this right and have written up in the chat box. I encourage you to tell us your answers as well. So the more you do, the better you will remember. Okay. Yeah. So this is what you do. Corrected anion gap is equal to 20 plus 2.5 multiplied by 4.5 minus 2.5. That is 5. That is 2 into 2.5 is 5. 20 plus 5 is 25 millimoles per liter. So that's how you can get correct. So they said we can use the traditional concept and we'll correct for anion gap. Okay, right. So that is the so anion gap itself was looking at electrolytes and they corrected it for albumin. So they said that should be fine. Okay, right. So Stewart's method, although it was very good and it gave an insight into the acid-base disorders, it was a little complicated, strong iron difference, SIG and all that. So it was popular with only one section of people, but most people said, no, it's too complicated for us to use. So David Story, Dr. David Story, an intensivist from Melbourne, Australia, he decided to simplify Stewart's approach and said we should be able to simplify it and take it to the bedside. Now that's what you want. You have a patient, you have an ICU full of these critically ill patients, you're looking at blood gas after blood gas, and you can't be going on spending a lot of time with each report, right? So it should be user-friendly. So he came up with this simplified Stewart approach. Okay, this approach would require the following. You need an arterial blood gas analysis, you need measurement of lactate and measurement of albumin, which is usually done for patients in the ICU anyway. Okay, so what do? He said the base excess is affected by sodium chloride, as we saw already, affected by albumin, affected by lactate, and affected by other ions. We know that, right? So he just put it into this equation. So he said, step 1, you calculate what is the sodium chloride base excess effect. Okay, so what you do is you look at the measured sodium minus measured chloride minus 35. That is in millimoles per liter. Step 2 is calculate albumin base excess effect. It is 0.25 multiplied by 42 minus measured albumin in grams per liter, so many millimoles per liter. So I think people might get a little confused here. In one slide I had 4.2 or 4.5 and here 42. Remember, if it is grams per liter, you will have a larger number here. If it's grams per deciliter, you'll have a smaller number, okay? So please don't get confused. Okay, then we have lactate base excess effect. Okay, if you're getting lactates in milligram per deciliter as we do, you'll have to change that to millimoles per liter. So conversion is here, 1 milligram percent is equal to 0.11 millimole per liter. So lactate base excess effect is equal to 1 minus measured lactate in millimoles per liter. And then you calculate other ions effect also. Okay, so you could simply put it this way. Base excess is equal to S plus A plus L plus T. Easy mnemonic for you to remember. Okay, right. So if we know base excess from your acid-base report, APG report, sodium chloride, you know, sodium base effect, albumin effect, you know, you can calculate lactate, you know. What you do not know is the T. So the other ion effect. Okay, so base excess is simple maths. Base excess minus S plus A plus L. Okay, so what are these other ions that we're talking about? Other ions that can affect acid base include measured and unmeasured cations and anions. The measured cations which you've not included in your calculations may be potassium, calcium, magnesium. You look at the reports. Okay, look at the patient. Unmeasured cations may be proteins, maybe the patient is on lithium, or maybe aluminum toxicity, for whatever. You look at that. Other anions may be phosphate, sulfate, ketones, as we already mentioned. Maybe there are a whole lot of other unknown anions that we may not be measuring. We don't know them. Yeah. So just to familiarize ourselves with this concept of David's story, let's look at this scenario. The same person in shock, almost the same numbers. Okay, let's just use David's story approach to see how it looks like. Okay, so I'll do that for you. Okay, so we have said in this is base excess is minus 10 millimoles per liter. We know that already. Okay, we will measure the sodium chloride effect. Okay, measured sodium minus measured chloride minus 35. So in the scenario, it says 132 minus 98 minus 35. Okay, if you do the maths, you get minus 1. Step 2, look at the albumin contribution to it. So 0.25 minus 42 minus 25, whatever, you get 4.25. Lactate, 1 minus measured lactate. Okay, what did we say was, okay. So 1 minus 4.95 millimoles per liter minus 3.95. And step 4, you have all of them put together. So the other ion effect will be equal to base excess minus S plus A plus L. You do the maths, you get minus 9.3. Okay, so what are you trying to do now? You know the base excess is minus 10 millimoles per liter. You know the patient has got metabolic acidosis. We knew all that already. So what is the additional information that you get from this David story approach? What you see is it's more quantitative now. You know how much of this acidosis is coming from where? So is there sodium chloride effect here? Not really, minus 1, that's not much. Okay, is albumin doing anything? Oh yes, it is 4.25. Okay, it is significant. It's actually producing metabolic alkalosis, which means the patient's metabolic acidosis is more than what you think. The albumin is actually masking that metabolic acidosis. It's having a protective effect, of course, but it's not normal. Okay, lactates are elevated. And mostly it is other ions that is in this effect. So this patient's acidosis is mainly other ions, minus 9.3. It's probably worse, albumin is protecting. So if you look at that case, what was it? Diabetes mellitus, patient in shock, and we didn't give you the blood sugar level. Quite likely it is high. And maybe the patient has got ketoacidosis. Maybe the other ions are ketones. So that is how you use that. Okay, so if you compare the acid-base disorder interpretation by the two methods, okay, right? Okay, so far I've explained to you both the traditional approach, and then I spoke about Stewart approach and the David story simplification of Stewart approach. Okay, and now I'm going to try and compare both the traditional method and David's story approach. Okay, so we have this patient who was returned to the ICU after a complex liver transplant. His APG shows the following. Okay, so if we analyze this, as you will agree with me, the patient has acidosis and it is a respiratory acidosis. we will calculate expected bicarb because it's respiratory acidosis. And it looks like he's just come from a liver transplant to the ICU. So his expected bicarb would be, it would be acute respiratory acidosis. So 0.1 multiplied by 8. 8 is 48 minus 40. So that's 0.8, it's 1 millimeter of mercury. Okay. So the bicarb should have been higher, should have been 25, but it's not 25, it's 18, which means there is additional metabolic acidosis. Whenever we find metabolic acidosis, we calculate anion gap. So I've added potassium here, you may or may not. Sodium plus potassium minus chloride plus bicarbonate, 21 millimoles per liter. So in any case, it is high. So patient has high anion gap, metabolic acidosis. His albumin is 1 gram per deciliter, very low. So you correct anion gap for the reduced albumin, you will get 29 millimoles per liter. Okay. So we're sure that is high anion gap metabolic acidosis. And then we have to do what is called gap analysis to look for any mixed disorders. So anion gap is 21 millimoles per liter minus 12 divided by 24 minus 18 is his bicarb. We get 9 by 6 is 1.5. So what did we say? Gap analysis, if it is more than 1, the patient has high anion gap acidosis plus metabolic alkalosis. So here you can see a patient having mixed disorder where there's metabolic acidosis plus metabolic alkalosis. So this is the traditional way of calculating or looking at acid-base disorder. Okay, for the same, we will use David-Storey approach. Okay, we know there is respiratory acidosis. We know there is metabolic acidosis also. And so we are now calculating based on David-Storey approach. What is the sodium chloride effect? 145 is the sodium, minus 111 is the chloride. So 145 minus 111 minus 35 is minus 1 millimole per liter. Albumin effect, we calculate, we get 8 millimoles per liter. Lactate, if we calculate, 1 minus 3.7, so minus 2.7. And other ions we calculate, we get 14.3, minus 14.3 millimoles per liter. So base excess was minus 10. Okay, so there is not much of sodium chloride effect. Albumin effect is huge. There's a lot of metabolic alkalosis because of that. It's plus 8. Lactate is not much. It's something else going on. And the patient, other ions, we don't know what they are. Maybe gelatins, maybe acetate, maybe gluconate, all the IV fluids that the patient might have got. So we'll have to wait for the patient to eliminate all these, for the patient to get back to normal. Okay, so this is how you analyze the acid-base report using David-Storey approach. So you know what is producing what. This minus 10 millimoles. You know albumin is having a protective effect over here. It's not good, but it's there. Okay, so it means the acidosis is much worse than what you think or what is shown there. So that's how you can make out. Okay, yeah, right. So how do we treat this patient? Now we have done all this calculation. What is the use? We know the patient has got respiratory acidosis. We can ventilate him some more. We know that his chloride is a little on the higher side, and so also the sodium. So continue to keep the sodium high. You can give him some sodium bicarbonate if you want, but reduce the chloride maybe by giving him some furosemide. His albumin is low. We would like to treat with giving albumin, but don't do it yet because he's got severe acidosis. There is some protection. So let him get better and then you give him albumin. His circulation needs to do better and needs to eliminate the lactate. Also, all these ions that we have already infused. Okay. And then once things are better, you can give him albumin and get him better. And of course, you will do repeat estimations also. So that is how a quantitative approach to acid-base analysis can be done using David-Storey approach. Okay, so the bicarbonate-centered strategies are less integrated with general plasma chemistry and appear less able to pinpoint specific components of acid-base disorders. They'll tell you the disorder, but they will not pinpoint what are the specific components. The Stewart approach, also the David-Storey approach, closely integrates acid-base physiology and clinical chemistry, providing detailed clinical strategies to manage acid-base disorders. So now I've covered all the 5 steps. Is there an acid-base disorder? Is there a respiratory disorder? If yes, evaluate. Is there a metabolic disorder? If yes, evaluate. Look for mixed disorders and use modified Stewart to do a quantitative check. Okay. So we've gone through all this. We need to integrate the interpretations. Okay. We'll now go on to try and calculate a few things. Okay. So we obviously have to practice, right? And so we have this case scenario. We have a fit and well 11-year-old boy presenting with diarrhea and vomiting. He's got non-specific abdominal pain. His ABG shows pH of 7.12, PCO2 of 25 millimeter of mercury, bicarb of 10 millimoles per liter, base excess minus 17 millimoles per liter, and glucose 400 milligram %. Classic description. What is the problem? Devika?
pH is low, so it's acidosis, and PCO2 is also low, ma'am. So it's a movement in the same direction. So it is metabolic acidosis. So in this case, the glucose is also quite high. So it and non-specific abdominal pain also. So it could be type 1 diabetes mellitus with the patient going into diabetic ketoacidosis.
Absolutely. So option you have to choose here is metabolic acidosis. Okay, we go on to the next situation. Okay, so the same case, what is the expected PCO2? We agreed he's got metabolic acidosis. What is the expected PCO2? Sweaker.
Hello, ma'am.
Yeah.
Yes, ma'am.
What is the expected?
Hello.
The same case. Okay, we know he's got metabolic acidosis. What is the expected PCO2? I've given the clue also in the equation, so it's easy for you to calculate.
Yes, ma'am. So if we go by the formula, we have to first calculate the delta bicarb.
Yep.
So that would be 24 minus 10. So 24 minus 10 is 14.
14.
So
yes,
yes, ma'am. So we take 1.2 and multiply by 14. So if we take 1.2, then multiply by 14, we get 16. So we take 40, which is what we take as the normal PCO2, and subtract 16 from this. So we'll get 24, which will be the expected PCO2.
all right. Nearly there. 23 is what I've written, but that's okay. Yeah, but you know how the calculation is done, right? Absolutely
Yes.
right. That's how we can do it. Okay, we go on to the next equation. I'm with the same person, same patient. Now we have additional numbers coming in. We know sodium is 140 millimoles per liter, chloride 100 millimoles per liter. What is the anion gap? Sitara?
Ma'am, anion gap is equal to sodium ions minus the sum of chloride and bicarbonate ions. So here the chloride ions are 100 and the bicarbonate is 10. So that will be 140 minus 110. So the anion gap is 30.
Perfect. Good. Very good. Okay, that's right. Okay. Now the same patient, now we know anion gap is 30 millimoles per liter. Let's do gap analysis. Okay. Whenever we have metabolic acidosis, anion gap is also there. We'll have to do next, look for mixed disorder. Anirudh, can you do gap analysis? The clue is already there.
All right, ma'am. So equating it in the gap analysis, anion gap excess shall be, that is 30, which is the calculated anion gap, observed anion gap, minus the normal anion gap, that is about 12, divided by the bicarb deficit, that is, or the delta bicarb. So normal bicarb is 24, minus the observed bicarb is 10. So equating it, 30 minus 12 will give us 18. Divided by 24 minus 10 is 14. So 18 divided by 14 will be 1.2. since it's more than 1, this shall be a high anion gap metabolic acidosis plus metabolic alkalosis.
Okay, so it shall be high anion gap metabolic acidosis and metabolic. You're absolutely right. Correct, correct. Okay, perfect. You're right. 18 by 14 is more than 1. Okay, you don't even need to calculate 1.2, 1.4. Yes, you can do that, of course, if you want to do subsequent one. But you're right, absolutely right. Good. Okay, now let us, the same numbers we have, I think we also now have albumin and lactate coming in. Analyzes metabolic acidosis and what is affecting his base excess the most. The clue is already given how you can calculate, okay? So we need to see A, B, C, and D, which is the worst contributor to this metabolic acidosis, minus 17 millimoles per liter. Okay, I want you to do the calculations. Jyoti, can you do the calculations? What is the problem in this patient?
Yes, ma'am.
Yeah.
So, ma'am, according to the formula, we'll calculate salt first. So that can be calculated by measured sodium minus measured chloride minus 35. So substituting the values, sodium is 140 here, 140 minus 100 minus 35. So that becomes 40 minus 35 will give you 5 millimoles per liter.
Okay.
Next is albumin. Albumin 0.25 into 42 minus measured albumin. Measured albumin here is 22. So 42 minus 22 becomes 20. 20 into 0.25 will give you 5 millimole per liter, ma'am.
Yep.
Next is the lactate. Lactate we can calculate by 1 minus measured lactate. That will be 1 minus 4 is equal to minus 3. Then we'll calculate the trash ions. Trash ions is equal to base excess minus the sum of the sodium chloride, albumin, and the lactate. Okay. So that will be minus 17 minus sodium chloride. Here we got it as 5 millimoles per liter. Then albumin again 5 millimole per liter. And then lactate is minus 3 millimole per liter. So minus 17 minus 5 plus 5, 10, 10 minus 3, 7. Minus 17 minus 7 will give you minus 24 millimole per liter.
Absolutely right. Perfect. Okay. So now I hope you get how it is done. Okay. So that is how. So you can see that in the minus 17 millimoles per liter, other ions are contributing a lot. Right. We know we said ketoacidosis, right? It's just illustrating some contribution from sodium chloride and albumin, but majority is other ions. Okay. Right. We have question 17 coming up. Okay. You're faced with an intubated and ventilated patient with known cirrhosis transferred to the emergency room for laparotomy. He's had saline resuscitation. A lot of numbers here. I hope it's not too difficult for you. I need to know what kind of acid, let's see, pH is 7.2. We know that is acidosis. PCO2 is normal. So we know it is metabolic acidosis. That is 15 millimoles per liter. Okay, is bicarbonate. And sodium is given, chloride is given, albumin is given, lactate is given, base excess is also given. Which of the following acid-base disorder does the patient have? Srimukhi?
Yes, ma'am. Ma'am, so anion gap would be sodium minus chloride plus bicarb. So that would be 133 minus. Chloride is 110, ma'am. Plus bicarb would be 15. So 133 minus 110 plus 15, that would be 125. So 133 minus 125, that would be 8 millimoles per liter, ma'am.
Okay.
So it's a normal anion gap metabolic acidosis.
Okay. Perfect. Okay. So normal anion. So it's less than 12 millimoles per liter. We said anion gap less than 12 is normal, isn't it? So it's got only 8 millimoles per liter. So it's now normal anion gap acidosis. Perfect. Okay. Now we so that's what I just calculated that for you. You're right. Okay. Question 18. Alankrita. Okay. The same case, we have David Story approach to be done now.
Okay, ma'am. We'll calculate sodium chloride effect by the formula. So measured sodium, which is 133, minus measured chloride, which is 110, minus 35, which comes to 133 minus 145, which is minus 12. Albumin effect we will calculate by 0.25 into 42 minus the albumin, which is 22 grams per liter. So it comes to 0.25 into 20, which comes to 5. Lactate effect is 1 minus the lactate in millimoles per liter, which is 1 minus 5, which is minus 4. And other ions we'll calculate by base excess minus S plus A plus L, which is minus 11.5 minus 12 plus 5 minus 4. It comes to minus 11.5 minus 11 which comes to plus minus 11.5 plus 11, which is minus 0.5.
Yeah, right. Okay. So, you're right.
Chloride effect is the most in this one.
Absolutely. Right. Okay. So you find that his base excess is minus 11.5 millimoles per liter. And you know the culprit is chloride here, right? Minus 12. So you have to correct this first. Okay, so you change your solution, whatever you're giving. He's had saline resuscitation is the clue there. Okay, so that is a major issue. And so if you correct that, I think this patient will get better. Okay, so that's how you use the David Story approach. And the last one to be done, I think, Vasudha, can you just exercise there?
Yes, ma'am. So in this, our base excess is minus 10. S will be equal to 145 minus chloride, which is 111 minus 35. So this will be equal to minus 111 plus, this will be equal to minus 1. Then the albumin excess will be equal to 0.25 into 42 minus 10. So this will be equal to 8.
Right.
Now lactates will be equal to 1 minus 3.7, which is equal to minus 2.7.
Correct.
So,
and let me help. Trash ions, when we, I call them trash, but other ions, you're right. So if you do all the calculations here, I'm just helping you, that's all, okay? Yes, so we get minus 14.3 millimoles per liter. Thank you, Vasudha. I'm just trying to help you, right? So the base excess that we find, minus 10 millimoles per liter, majority is coming from the other ions, minus 14.3 millimoles per liter, some protective effect of albumin as we had the other case also, okay? So these could be sulfates, phosphates, ketones, acetone, gluconate, whatever. So you have to look for that, okay? Yes. You're right, okay? The last one that I just wanted to tell you. So this was the case of metabolic alkalosis that we had discussed in part 1, right? So we had a patient having chloride being very low. Okay, so he is most likely having saline responsive metabolic alkalosis. I said we should look for the reason, and this patient's potassium was very low, 2.5 millimoles per liter. You must treat using that. You could use the David Story approach and actually quantitate that also. Okay. But just the other thing that I wanted to mention, this patient has a lot of chloride deficit. If you want to quantitate chloride deficit, you can use this formula, 0.2 multiplied by body weight multiplied by the normal chloride you could take as 100 minus 80. Okay, so that is 20. 0.2 multiplied by 70 multiplied by 20, you get to 80 millimoles. So that is the chloride deficit the patient might have. And so you just need to give saline to the patient. How much saline to be given? You can use the formula. 280 millimoles is our requirement. 144 millimoles per liter is what saline has, the amount of chloride. So patient would require about 1.8 liters of saline for resuscitation. So how fast or slow should you give? You can give it at a rate of say 100 ml per hour, but plus losses that the patient might have. Okay, so this is a formula that you can use to correct chloride deficits. I wanted to say this for completion's sake. Okay, in addition, you will have to treat his hypokalemia, and if it doesn't respond, look for magnesium deficiency as well. Okay, so In the acid-base physiology workshop that I have done, along with the preliminary reading material that I sent, I have told you what is a hydrogen ion, what is a mole, what is pH, what is an acid, what is a base, what are buffers. We covered the Henderson-Hasselbalch equation. How is the acid-base balance regulated? What are the primary acid-base disorders and the secondary responses? Avoid pre-analytical errors. What is the information available on ABG report? And we have to assess oxygenation, ventilation, and then look at the acid-base disorders. So you look at step 1, is there an acid-base disorder? Yes or no? Is there a respiratory disorder? If yes, is it acute or chronic? Evaluate the compensation. Step 3, is there a metabolic disorder? If yes, is it acidosis? If it is so, calculate anion gap. Is it high anion gap metabolic acidosis or normal anion gap metabolic acidosis? If it is not acidosis, but if it is alkalosis, is it chloride responsive or not? You also look for mixed disorders. You can do gap analysis to do that. And simple would be to use David Story's approach to do a quantitative check of identifying what disorder is contributing most to the patient's condition. Okay, so a bit of salt is good for the body, right? You remember that? Okay, and thank you very much. Okay. David Story, I had invited him to attend this workshop, but as I said, 1:30 to 2 a.m. will be really an unearthly hour. So I don't think but that is him, Foundation Chair of Anesthesia at University of Melbourne. And I'm sure he will be available by email if you wish. His email will be available on the net if you like. You can communicate, he communicates well if you have any doubts about his approach. Yeah, that brings us to the end of my workshop. Thank you.
Thank you once again, ma'am, for a stimulating talk that many find complicated and often very challenging. A pretest was sent to the registrants along with the reading